Vitamin D to improve outcomes by leveraging early treatment while at trial. By the National Heart, Lung and Blood Institute, VITAL's Clinical Trials Network, published in NEJM on 11th December 2019. Background. Observational data suggests that vitamin D deficiency is common in critically ill. Previous single-center phase 2 VITAL ICU trial regarding vitamin D3 supplementation in deficient critically ill patients observed that it didn't reduce the hospital stay, hospital mortality, or 6 months mortality. But the investigators observed lower mortality at day 28 and 6 months in severely deficient, although the trial was underpowered for analysis of mortality as an endpoint. Post hoc analysis of VITAL ICU showed that exclusion of patients with early death and early discharge within 7 days showed mortality benefit in vitamin D group. Meta-analysis by Wang et al. Purju et al. Suggested that vitamin D levels associated with high mortality and early high-dose supplementation improves mortality. It is hypothesis generating for need for larger phase 3 trials. Hypothesis. Early administration of high-dose vitamin D3 would reduce 90-day all-cause location mortality among critically ill vitamin D deficient patients who are at high risk for death. Methods. Multi-center double-blinded placebo-controlled phase 3 trial. All patients were randomized within 12 hours of ICU admission among 44 centers in USA from April 2017 to July 2018. Recruitment was stopped after the first interim analysis based on the predictive mortality that vitamin D is beneficial in less than 2%. Planned intervention. Vitamin D levels are screened by point of care test and confirmed by liquid chromatography tandem mass spectrometry. Intervention group received a single enteral dose of vitamin D3 of 540,000 international units and threshold for supplementation is level less than 20 nanograms per ml. Randomized within 12 hours and vitamin D3 was administered within 2 hours of randomization. Inclusion criteria. Adult patients with one or more acute risk factors for death or lung injury contributed to ICU admission. The risk factors are pneumonia, sepsis and shock, mechanical ventilation, aspiration, smoke inhalation, pancreatitis, and lung contusion. Exclusion criteria. More than 12 hours after ICU admission, more than 70 hours after hospital presentation, known kidney stones, baseline serum calcium levels more than 10.2, ionized calcium levels more than 5.2, unable to take medication centrally, mechanical ventilation exclusions, and unable to take consent. Flow of participants through the trial. 15,924 patients were screened and 2,624 gave consent. 1,360 patients screened positive for vitamin D deficiency. 690 were assigned to vitamin D group and 538 were included in the analysis. 668 patients were assigned to placebo group and 540 were included in the analysis. Flow of participants through the trial. With the intention of admission to ICU, patients with more than one risk factor screened for vitamin D deficiency and randomized into placebo group or vitamin D group within 12 hours of ICU admission, and the prescribed drug has been administered within 2 hours after randomization and followed up further. Randomization and statistical analysis. Central electronic system with permitted blocks to randomly assign eligible patients in 1:1 ratio, stratified according to the site. Avoided vitamin D supplementation or testing within 1 month of administration of either drug or placebo. Sample size calculated was 3000 for 87% power of the study with an alpha error of 0.05. Analysis included patients only with confirmed low levels by liquid chromatography and tandem spectrometry, and prior stopping futility rules are applied priorly. Primary and secondary endpoint. Primary endpoint 90-day all cause all location mortality. Secondary endpoint hospital length of stay to day 90, death from any cause at day 28, ventilator free days to day 28, time to death to day 90 and quality of life at day 90 and secondary physiological endpoints as described. Among primary endpoints, there is no significant difference among placebo group and vitamin D group in terms of mortality. Among secondary endpoints, there is no statistically significant difference among vitamin D and placebo groups in terms of death at day 28, death at hospital at day 90, ventilator free days at day 28, or change in quality of life. Among secondary physiological endpoints in both the groups, there is no statistical difference in terms of new mechanical ventilation or new ARDS at day 7 or highest serum creatinine on day 7 or other factors. But there has been significantly high vitamin D3 level was noticed on day 3 in vitamin D group. Among secondary safety points, there is no significant difference among vitamin D and placebo groups either in terms of hypercalcemia or highest serum calcium level at day 14 or highest calcium level at day 14 or kidney stones at day 90, falls at day 90 and falls related fractures at day 90. Compared to baseline vitamin D3 level and mortality, there is no statistically significant difference in mortality even in severely deficient population among both the groups. Subgroup analysis and mortality. Observed mortality was higher in vitamin D group with sepsis infection in primary analysis population and pneumonia infection and pre-randomization ARDS in screen deficient population. Strengths of this trial. Enrolled intended population in blinded fashion. 90-day mortality similar to predefined estimate. Robust vitamin D responses noted. Limitations of this trial. Exclusion of patients later in course of critical illness. Didn't follow the outcomes in patients who are not vitamin deficient at screening, and there is no additional vitamin D supplementation after early loading was used. In comparison with VITAL ICU trial, early inclusion of patients compared to the VITAL ICU trial enrolled typical medical patients. No additional supplementation was used and used liquid chromatography tandem mass spectrometry. And there is a wide difference in the racic and ethnic diversity of population screened. In conclusion, early administration of high-dose enteral vitamin D3 didn't provide an advantage over placebo or other measures of non-fatal outcomes among critically ill patients with vitamin D deficiency. Does it change my practice? My current practice is not to routinely screen all patients for vitamin D3 or to supplement with vitamin D3 at ICU admission. This trial doesn't further add on to my understanding of vitamin D supplementation in critically ill adults. I prefer to screen and supplement only in specific population like difficulty in weaning and in long-term ICU patients. Future steps. Vitalized study by ESICM group. High-dose vitamin D3 on 28-day mortality in adult critically ill patients with severe vitamin D deficiency that is less than 12 nanograms per ml is on the way.
We are grateful to Dr. Rajesh for this wonderful presentation and check our website for further details. Thank you.